Okay, hello dear doctors. This is Dr. Sharia, and I hope so you all are attending the class. Today is a topic which is related to endocrine. It's a diabetes mellitus related to endocrine system. I hope so all of you will enjoy the class and stay for a certain period so that we start the class. Thank you so much. Okay, hello dear doctors, this is Dr. Sharier, as you can see me in the screen. So we're going to, conduct the diabetes class in the beginning. Yeah, so it's a part of a major part of endocrine system. So like to give you a demonstration and all this thing on this hot topic. That's the diabetes mellitus. After starting the timer, I finished my lunch actually. No such time, to be honest. Also, finishing the class, I have to go for my sister's marriage, which is going on. Maybe you have seen in the pictures. So, okay, so diabetes mellitus, then, okay, this is me. And, after that, we'll go for some of the topic outline. And if you are a John Murthak user, first of all, there has already been a chapter given on John in the John Murthak. That's 187 page, guys. Or you can see there's already a chapter, like separate chapter is present in John Murthak. All right, so you can just go and I think check that one. So, so it will be fine. I hope so. Great. So this is the page number, John Murthak. If you want, you can open that one. And apart from that, like there will be some of the hot topics which we are going to discuss today, which consist of theory at the same time. There are some recalls at the same time. So I just made some of the quick outline so that would be useful for the diabetes mellitus. But it will be better if we see this one at the end. After finishing the topic which is related to recall. So those recall, the hot topics, I just put it into the topic outline side. Okay, so this will be much more interesting as like a bullet points when we'll be finishing that other part. Actually, I hope so you're understanding. So it's better we do the theory, we do the recalls, and then we come to this topic outline. So this would be better, but I'm just giving you like how it what are the topic it looks like and what are the topics that's been tested. So yes, general features of diabetes and all these things, and certain drug combination they like to give, as you can see in the two. Elderly, painful muscle wasting, another topic. Neuropathy, sometime they will be asking. Features of cranial nerve palsy, features of cranial nerve palsy that can be asked. We have seen in past is asking about that one. So in the slide two, certain topic like oral hypoglycemic agents, sulfonylurea, we will be discussing everything, so you don't have to worry about this thing. So we'll come back to this topic later. So black pigmentation in shoulder, as you can see, acanthosis nigricans, child with unconscious first time, like what we should like. We will be discussing. I'm just giving you outline. We will come back to this slide again. So I'm just giving little outline so that you understand. A child become unconscious. So you see one thing, the child become unconscious, they often ask this thing. So second time, what to check. First time, what to check. Unconscious baby, what to check. So we'll be discussing diabetic foot. Don't forget, it's also very important. Okay. So management of diabetic ketoacidosis, always you go for IV fluid and all this thing is important. Apart from that, there's like, learn management of diabetic ketoacidosis, initial resuscitation. So let me show you the slide. You can check the slide. I'm giving you a few seconds for overview, but we'll come back to this slide. Okay, let me put my charger. My charge is going down. Okay, so I'm back now. So, these are the also certain interesting things, which, a lot of topic you can see from diabetic foot. If you can monitor a lot of topics. So I made very nice slides for this diabetes one. I hope so you will enjoy. All right, guys. So, we'll be coming back to this one later, but for now, I'm just giving you overview. When you see things, so always do, even in life, even for study, whatever you plan, whatever you do, you make an outline first. So that's always better if you make some kind of outline in the beginning. All right. So topic outline the four, drugs causing gynecomastia. Gynecomastia is a super hot topic, guys. Gestational diabetes, as you can see, diabetes normal level, diabetes with hypertension, with antihypertensive. What is the choice of drug? Like that's how it can be tested. Sometimes a mechanism, but to be honest, the drug pharma, the mechanism is not tested in AMC in that way. But I just put it actually. But one question was tested. What was that one question? I will be telling in the class actually. So diabetic retinopathy and hypertensive retinopathy. This one part, guys, this one part we don't teach here. We teach it in, eye or the ophthalmology section. This part we teach in eye or the, ophthalmology section. All right. So this is the one part because it includes a lot of, things are there, which you need to see the fundoscope and things out there. All right. So as you can see, guys, this is the part. Is there any other slides? Okay, so I made some nice outlines so that things would be much easy for you to overcome the things, right? Now let's getting into today's class topic, like the main slides, like diabetes mellitus for the AMC. All right. Now, certain things, we have a separate topic already. So we have a separate topic that is John Murtagh, that's the topic. All right. John Murtagh. So that's the topic actually here. All right. Then AMC handbook, this Kaplan, Davidson, and some med bullets, you can tell little help. But this is one of the main thing. The main thing I would say, if you follow my lecture well, that will be more than enough. All right. So this is the thing to remember. Handbook, we don't have separate specific pages for diabetes. All right. Handbook, we don't have specific pages for diabetes. You can search of your own. All right. Now, Kaplan, I won't recommend that much. Let's give a cross. Davidson, I think, if you just follow my slide, that will be enough. Okay, med bullets is always good. So good, actually, med bullets. You can just search with this topic, diabetes, you will find a lot of things in med bullets. So this is the outline and the references which we might be using. Now, let's start solving a problem. So you guys try to participate in the comment section. An obese female comes with a black pigmented area around the neck. Now, her random blood sugar is 14 millimole per liter. So what is the possible diagnosis? What is the possible diagnosis? Any idea, guys? Search with this topic, diabetes. All right, so waiting for the answer. This is nothing but, this is acanthosis nigricans. This is a condition, which can be developed in metabolic syndrome. This is actually somewhere related to metabolic syndrome, which is somewhere related to, there's a triad we say, so diabetes mellitus, that person has, hypertension, this person has also, hyperlipidemia. So there is a ton of problem they have. So hyperlipidemia, these are thing, and most cases these people are obese. Even if you're traveling, I remember I was traveling in local bus, and a person was sitting just in front of me, and later that one person just get up from that seat, and I got seated near to him, and he was talking, what do you do? He said, I'm a doctor. And then you see, so by conversation I told him, if you don't mind, I have a conversation, something to tell. He said, yeah, no problem. Like, see, have you ever marked like there's some scar mark and things? He said, yes, I'm concerned about it. Like, especially he was talking about cosmetic. I told him, like, it's not about that one. this is probably an indicator that you might have hyperlipidemia thing. So why don't you check the cholesterol level? So I just quickly write one thing and give him, and so later it was find out that it was actually hyperlipidemia. So it's not a tough thing actually. In day-to-day life you can see people having, so this is very easy to make a diagnosis actually. So acanthosis nigricans, as you can see, this is the page which I take from Davidson medicine, so which you can use probably. So in Davidson medicine, usually you started with some pictures in the beginning, which I really like actually. So just for understanding purpose, if you ever find this kind of finding, so from now on, if ever any diabetes patient come and if they give you chronic history, you will ask them to do this kind of thing. So this is called some kind of the prayer sign. This is called some kind of prayer sign. And then there could be some kind of skin condition which is fine. And as we just discussed, that is acanthosis nigricans. And leg might also have some issues in diabetes. Actually, whole body, the immunity is suppressed. It manifestation as skin problem, manifests as blood pressure related problem, manifests as another skin problem, that is acanthosis nigricans, but that is the indicator of metabolic syndrome as hyperlipidemia. And one of the biggest problem is diabetic foot. Okay, so it is diabetic foot. Next up is the other part. Actually, the other part is missing here. As you can see, it was a big chart given in Davidson. So the other half of this one is given. We check certain things, carotid pulses and on all these things. Why carotid pulse? Because hyperlipidemia. I repeat, why we check carotid pulse in diabetes? It's because we check, like, is it bulging well, or if there is any extra lipid deposit because of the hyperlipidemia. So we check that kind of thing. Okay, so this is important. And also sometimes we check some of the skin conditions. Yes, cranial nerve palsy, this is another thing to mark, guys. Cranial nerve palsy can happen. Okay, not the least, like this is the eye problem, which can call diabetic retinopathy. Diabetic retinopathy, the fundus related problem. There is a lot of stages which we will teach you in ophthalmology section. Okay, so and since they took insulin, so insulin injection site might have some lipodystrophic type of issues. All right, so this is fine, guys. And now the next topic that is coming, the differences. I hope so you're writing. This is a class today which might include a lot of writing things actually. All right, so let's come in some little comparison between the type 1 and the type 2. Now we all understand like which one is common. Is of course the type 2 diabetes is always that's quite a common. The type 2 is always quite a common. So you can see 90 to 95. All the people you see is mostly type 2. I have a relative who is my wife's cousin actually. So she's having actually, her age is like 24, but she's having diabetes. Now she's having type 1 diabetes because it's diagnosed before 30 actually. From childhood she's having issues, and for that purpose she has to take insulin, in fact actually. So this is something runs in the family, which is actually type 1 diabetes mellitus. All right, so now you need to understand why type 1 thing happen. Type 1 usually is a certain thing that usually happens because of this pathogenesis. Like this total lack of insulin, the pancreas, the islet of that particular cell does not have anything to give you, like actually. So there'll be total lack of insulin and all this thing. And in the right hand side, there's a relative deficiency of insulin. There are something which you can stimulate, you can do something. So for type 1, there is no way you can give oral hypoglycemic agent. But for the type 2, you can definitely start with oral hypoglycemic agent as monotherapy. I'm using a term monotherapy. We usually started with metformin 500 as monotherapy. But before starting any drug, we always try to adjust the lifestyle modification. If lifestyle modification not working, then only we switch to drug. If drugs are not working, we switch to insulin, or we do some combination. So let's make the summary. The left hand side is total lack of insulin, type 1 diabetes. So we give insulin directly in first. the right hand side, relative deficiency of insulin, so you can stimulate the islet of cell and all these things, even by exercise, even by a lot of other means you can do that. All right. So the common problem with diabetes, I think everyone knows, like polyuria, polydipsia, polyphagia. So these are one of those. So who can explain? Like, this is a very basic thing. Let's ask a nice to know question. Like, why polyuria in diabetes mellitus? Does anyone know? So why polyuria in diabetes mellitus? Does anyone know? Yes. No side questions, please. If anyone, I have an option for blocking. Okay. This time I decided those will be unnecessary giving us messages and things. I'll be just put that option block. So you'll be never can contact me over the messenger and all this thing in next time. Okay. But you can attend class even though after that, but in future you can't comment. So during live class, please don't make any unnecessary things actually. Yeah. All right. Line is totally fine. We are monitoring. We'll be telling you if there is interruption. We'll be telling you. Line is totally fine now. Yes. No other comments. Please do not put any kind of other comment. Please do not put any kind of other comment. I'm using a professional studio line. There is no chance there would be any sort of problem. If there is problem, this is a warning notice. Those are writing any other single thing. I'm telling, I'm very strict about this thing. If there is a single comment that comes, like, about apart from study interruption and refresh the page, I'll be just immediately block that person, right? So just be quiet. Mr. Khalid is also monitoring, Tanmoy is monitoring. If there is any problem, we will be noticing you. So please, unnecessary thing, don't spoil my mood and don't allow me to block you actually in messenger. Okay, we blocked 2 doctors last day. Okay, I also asked Mr. Khaled, if unnecessary messages some doctor give, just block them actually. They can attend class, but they can never contact us ever. All right. So next time, please be careful about in the live classes. This is a strict warning this time. With this batch, I think so soft. I think some other my class monitor was telling, doctor, you are very strict in last batch. This batch, you are a little soft, I think. So people, I think, is not listening to this. Line is absolutely good. This is studio line. This is like for channel broadcasting. How come problem can happen? You check your own line. So this is first and last warning. I'm removing all the comment things. I'm not going to watch it for next half an hour. So no matter whatever you say, I'll not be going to see it anything. Okay. So so this is the thing, and please do not spoil the mood in the beginning of the class. You check your own line. If there will be any problem, I'm telling strictly again, I will be notifying you because I'm also monitoring things. All right. So okay, let's get into this one. And a strict thing, it's your job. Like, if you ever say this kind of problem, if you will be blocked from my messenger, we'll not be responsible for that. Okay. So polyuria, polydipsia, polyphagia, and in the beginning of the class, we also don't want to, when we start a nice class, it's better let's have a nice class actually. Okay, so you see, like, do not write. I think some doctor is making, one my class monitor says, some doctors intentionally telling in that way so that you always keep the recording. That's why some doctors are doing like this. Okay, so we also get to know that one actually. So I'll be very strict from now on. I'm telling you, I have a good reputation of soft-hearted, but sometimes very bad reputation about very being strict actually. So recording things, you can't message me ever, anything, whatever, what happening. Please do not message me over my messenger. You will be immediately blocked. Okay, I might be harsh, but it's for the betterment for everyone. Okay, you want to pass or you want to just messaging me all the time, right? So just be strictly, I'm telling, first and last warning. Still those won't be listening and maintaining will be removed from the batch immediately, strict, suspended from batch. All right. So let's coming to this one. So no single messages about interruption and all this thing. Whatever thing happen, you can't message on that one during live class. As 2% is monitoring already. So I don't want to talk about this thing now. Okay. So let's just start from the beginning, and I hope so there will be any word from interruption. You check with your another line actually. All right. I think it was my mistake. I checked the message again. Okay, so no messages actually. This batch, I'm not very happy, to be honest. I'm thinking to hand over the class to Dr. Tanmay. I focus on that, special recall batch. It will be better, I think, for you guys. Okay, he's also good teacher. Okay, so this type 1, this is the percentage. Type 2, this is the percentage. I mentioned there is a one relative I was talking, less than 30 years. She was having type 1 diabetes. It's because her age is like 23, as I mentioned. Now next thing is lack of insulin. Lack of insulin, this is the pathogenesis, and there's a relatively deficiency of insulin. This is type 2 diabetes mellitus. All right. After that, polyuria, polydipsia, polyphagia. This is another part. Okay. And apart from polyuria, polydipsia, also common in type 2 diabetes mellitus. And apart from that, type 1 diabetes mellitus, the complication can happen. It is ketoacidosis. Complication can happen. That is ketoacidosis. All right. Ketoacidosis. In case of type 1 diabetes mellitus, since you don't have anything, total lack of insulin, so that's why we are using insulin. But in case of type 2, we can adjust with first lifestyle modification, then oral hypoglycemic agent, then insulin thing. What are the causes of diabetes mellitus? Okay, so lot of causes. So if you just go there, so the causes are, this is total lack and this is relative deficiency. Total lack and relative deficiency. These are the main causes, but there are trigger factors like a virus that is entering and attack the pancreas and all this part, certain thing can happen. All right. What are the causes of diabetes mellitus? Okay, so that's indicate that particular chart. What are the infections are common in diabetes mellitus? Staph aureus and the candida. Staph aureus and the candida. So these are the main things. Sometimes they might be mixing with some of the option A, B, C, D, E. A, B, C, D, and E. These are the things they will be using. All right. So you have to pick up this one, Staph aureus or the candida. Both they won't give you because both are common actually. All right. Now, some of the skin presentation, if you're following John Murtagh, you might find these pictures actually. But, the gentle picture we can't show because of Facebook has a lot of restrictions. Now, candida related problem, staph related problem. So this is the reference. This is taken from John Murtagh. Okay, so the two picture we show, one of them was web space. You already know with web space related problem, web space means this is called web space. This is another place for scabies actually. Okay, another place for scabies. Now risk factors of diabetes mellitus. This is a so-so thing. Just give a tick, at your convenient time, you will see that one. What could be the risk? Okay, so how this is important. This is important when you check a question. In the question, they will be mentioning someone who is 55 years and obese. So when someone is obese, so definitely that is relative deficiency of insulin. And relative deficiency insulin, this is mostly happens due to resistance, due to insulin resistance. Why type 2 diabetes happens? Insulin resistance. Now, how come insulin resistance thing happen? That is quite interesting. So insulin resistant thing happens, say, if a person who he is like lean and thin, maybe he is having 4 receptor for controlling the blood sugar level. The same person now become like this. He is still having this same 4 receptor, right, to control, but his blood sugar level is already bit up. Now, do you think this 4 is enough to control this? The answer is no. This is not enough to control, the blood sugar level, because the receptor level is not changed. Receptor level, you can't increase in number. Those are genetic related. So this is the thing. So this is called actually insulin resistance, as you can see. Okay, and you need to know some risk factors, as you can see. Just read them at your convenient time. Like African Caribbean, sometimes they start a question when we're going for the USMLE exams. So they always start the question, African Caribbean. So, some of the topic that strike our brain is like example, sickle cell anemia, thalassemia, diabetes, so these are African Caribbean, that can be some of the risks. So that's how it can be presented in the question. Or they'll tell you the family has diabetes, so he's in risk. So that's how things are there. Okay, so what are the skin presentations? So skin presentations are like this. Skin presentations are this: type 1 diabetes mellitus, type 1 diabetes mellitus. So this is just a so-so thing. I'm just skipping some of the slides. Symptom-related complication. You can also see these all are taken from the John Murtagh mostly. Okay. So skin infection, polyneuropathy, impotency, arterial disease. Actually, there's another way to remember this particular complications of diabetes. Like you can remember as macrovascular or microvascular complication too. There's a macrovascular complication and microvascular complication. You can check it from the Davidson's medicine. There is a nice chart given: macrovascular complication of diabetes, microvascular complication of diabetes. So sometimes do open a book and find out some charts is better for you actually. Like say macro means big. Macrovascular complication is one of the things, say the bigger things like stroke, the myocardial infarction, right? Like Berger's disease, mesenteric ischemia. These are the bigger complication. And some of the microvascular complication: diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, also diabetic foot related problem. So all the retinopathy, nephropathy, neuropathy, those are probably microvascular, some of the complications. Okay, so this is how we can also differentiate. Some of the other complication is common, like especially two dangerous complication. Let me tell you, two dangerous complication. One for type 1, you need to remember that one is DKA, diabetic ketoacidosis. It can also happen with type 2 diabetes, but DKA is type 1 diabetes mellitus. This is the thing. And the type 2 related complication is honk. Type 2 related problem, it is called honk. Okay. So that's the thing. I think I let you write this thing. I'll give you 1 minute break. Okay. You write the things which I just said. So keep writing. Okay, check my line. Everything is totally perfect so far. Everyone is monitoring my line. Khaled, Tanmay. So it's totally fine. Just information. Okay. So what are the clinical features of diabetes mellitus? Some of the common features: polyuria, polydipsia, and polyphagia. So 3P, and one of the question I asked, why polyuria? Because of glucose. So increase glucose level. So glucose level that's been increased. So when glucose that comes into the the tube and the tubule, say glucose particle after crossing the glomerulus, glucose is a osmotically active particle. It likes water. So when it comes to by crossing the glomerulus, it also carries water with it. Okay, so that is the reason more water is coming, and that is leading to polyuria. Right? So this is the thing. So very commonly we check these three things plus the weight loss. So this is a very common factor. Women is having recurrent, upper. So this is a common question in our AMC exam. Women is having recurrent, UTI, urinary tract infection. So there's a recall question. So what to check? Should we check the go for urine analysis or blood sugar level? So answer is a very popular question. So that's why I brought in that way. So should check fasting blood sugar. I repeat, we should check fasting blood sugar. Because why recurrent UTI? Because there could be underlying diabetes. Underlying diabetes can cause immune suppression. I repeat, underlying diabetes can cause immune suppression, and a female with decreased immunity is always having chances of UTI. So double check the fasting blood sugar. What are the clinical features of diabetes mellitus? Okay, so these are the clinical features, cardiovascular thing, and these things are mentioned. Just check. This is a so-so thing, nothing to teach here. In Australia, if you found a child's RBS is high, what to do next? In Australia, if you found a child's random blood sugar is fast or high, what to do next? Okay. So refer to multidisciplinary diabetes team. I repeat, it should be referred to multidisciplinary diabetes team. And do not perform OGTT in very young. I repeat, do not perform OGTT in very young. So this is the important information. They will be tempting you with OGTT, but OGTT we don't perform in very young. Okay. So refer to multidisciplinary team. If you find this one, this should be your answer. So investigation, yes, we have fasting blood sugar. You need to know the normal ranges. I'm sure you can check it from the book by yourself. Normal ranges of diabetes, fasting to be read 2 hours after breakfast, and especially after the OGTT. So learn all the ranges. Learn all the ranges. So this is important. So a 38 years Australian Aborigine come to you for routine checkup. What to perform in diabetic profile? Okay, so this part probably is little bit changing compared to previously. I have to check the red book and update you later in the screening part. Okay, so I heard there is little bit update that is going on, but so far in the books probably it is mentioned like normally we perform for a normal person after the 40 years. I repeat, for a normal person we start performing like diabetic checkup after 40 years, and in case of Aborigine it is 35 years. And what I remember, the guideline is changing a little bit. So guideline is changing. Okay, what I remember, the guideline is changing a little bit. All right, so this is important. The guideline is changing, so we have to cross check the new one. For this one I'll be update you later, or if someone already have it, please try to upload in our secret group. All right, so but I heard there is little bit update going on now about the Aborigine screening actually. Okay, my job is to tell you the things important. Not everything a mentor can teach, right? Okay, so this is the normal ranges. As you can see, these are the normal ranges. Normal ranges you can do of your own. Additional point, screening of type 2 diabetes. See information, these are John Murtagh lines, you can understand. Every 3 yearly, especially I want to highlight this line was tested in AMC. How randomly we do it? 3 yearly. 3 yearly. And annually from high risk, like family, there is everyone diabetic and all this thing. For this part, I think you can also check red book a little bit. There is a book which his name is Red Book. So high risk zone patient can do it annually, otherwise 3 yearly. Right. So diabetes related complications. I repeat, some of the diabetes related complication. Okay. Now, a complication, if you see a person who has diabetes, obesity, hypertension with family history of stroke present, what to do next? Diabetes, obesity, hypertension. So all the things are present. So all these things together, probably you can say even metabolic syndrome. And of course, family history also is there. So it's diabetic and thing can happen. So this question you have to pick up. Sometime, understanding question is also part of exam. I repeat this word, repeat this sentence. Understanding the question also part of exam. Now, thing is diabetes and hypertension. So, your first job is to control the hypertension. I repeat, in between diabetes, so sugar, and in between hypertension, the BP, which one you like to control first? Definitely you want to control blood pressure first, because it can be related to immediate complication. Diabetes will not probably cause immediate complication, right? So we need to control this one first, and that's the reason we go for this one, ACE inhibitor. So the choice of drug, I repeat, the choice of antihypertensive in diabetes cases is ACE inhibitor. ACE inhibitor. And one of the reason is, if this is afferent, if the Bowman's capsule, glomerulus, tubule, this is called afferent, this is called efferent. Okay, so when you give that person ramipril, it works in the efferent side, and it at least corrects the the losing some of the more protein and all this thing into the urine. Okay, the reason of giving a C inhibitor in a diabetes case to correct more of the proteinuria. Okay, so this is one of the important thing. All right. So diabetic related some of the treatment. All right. So few of the things, few things are extra written. So don't worry. Best initial step in management in diabetes is always diet and exercise. Okay, I hope so you're writing. Now, if it is failed, you start thinking about monotherapy. Diet exercise is not like first time came and next time came it is high and you just change. It's not like that. You will monitor him for a while with different diet and exercise and motivation. If it fails, then you start the monotherapy, that is metformin. All right, metformin. So in the metformin cases, like you can also go for dual therapy if single metformin not working well. All right, so more than 9, and the range is given, and if the patient has also complication. So remember one thing, if the patient is started having complication, I repeat, if the patient started to having complication, you always better switch to insulin therapy. If the patient does not, in that case you can go with the oral hypoglycemic agents or in combination. Okay, so that's how question would be tested. You have to be ready for this particular things. Why metformin not used in renal impairment? That was a AMC question. So anyone have any little idea why metformin not used in case of renal impairment? The reason behind that one is chances of lactic acidosis. So LA is a dangerous condition. Please write this one. LA is a dangerous, and just draw a picture of kidney near to it. So it can be very dangerous, of development of lactic acidosis. Okay, so this is the reason not used in case of renal impairment. Now, some oral and hypoglycemic, or normally we write in that way, oral hypoglycemic agent. So you need to know the drug names. Like there are groups of drugs, right? Sulfonylurea, the metformin, thiazolidinedione, GLP-1, okay, and also sitagliptin, GLP, so all these things, new ones are coming, and a particular thing have their own side effects and all these things. The particular of them has their own side effects and all this thing, right? So but this one thing is important for you to remember. We start this one as mono, and later you can make combinations actually. Okay, all the oral hypoglycemic agents can cause hypoglycemia. Okay, just remember one thing, all the oral, especially sulfonylurea, this is very common of causing hypoglycemia. All of them can cause, but this is, I think, more rapid, they down the blood sugar level, and in that sense metformin is a better drug. Okay, also to be considered, metformin is used in case of obese. It's a very good drug for obese. Even a lot of people, they like to take metformin of their own just to reduce even weight. All right, so this is a drug also can be used for reducing weight and all these things. Okay, name one diabetic drug that can cause weight loss. Okay, so metformin it can be, but even more better nowadays, exenatide. The name is exenatide. So metformin usually we use in the obese cases. Sulfonylurea we don't use in obese cases usually. I'm using the word usually. So name one drug that can cause weight loss. So exenatide. So this is the thing, metformin, and it has certain thing, including the one to remember is a renal disease, but it can also cause kidney disease. But for our AMC, we'll just remember this one. Lactic acidosis can be started alone, can be, as monotherapy or later as a combination. The dangerous side effect is lactic acidosis. Okay. Sulfonylurea, the problem is weight gain. So just write a line, never use in obese. All right. And increased risk of hypoglycemia. So it's all my lines, important lines. Increased risk of hypoglycemia. I think more, it should be used this word more. Okay. And especially you also need to know. Some doctor ask me, doctor, do we need to remember the names of sulfonyl? Under sulfonyl like glyphosate? Yes. The answer is yes. Because in the question they just mentioned drug name separately. So the patient is on glyphosate. Now, if you don't know is glyphosate is under sulfonylurea or metformin or thiazolidinedione, you will be in trouble, right? So we also need to learn these drug names. Thiazolidinedione, this is one of the thing. It has some adverse effect on the liver as well. Some adverse effect on the liver. Right. Not that much required, but just a extra thing here, MEN syndrome. Okay, MEN 1 and MEN 2. So MEN 2 is part of our endocrine thing as well, so it has association with some of the cancer. So it should not be used. So GLP-1, it should not be used, like the name of GLP-1 is given here, like exenatide. So we should not be using these drugs, especially if MEN association is there. Also, stop taking if symptom of acute pancreatitis. Please take note on these two things. But why it is popular and getting popular? Because it has weight loss property. Like now, compare and contrast type of question. There was a nice, contraceptive, when it was advertised, it was mentioned that, this oral contraceptive pill also reduces weight, and certainly that, pill become a super hit that time. Just because of that tagline, actually they don't increase the weight. So not increasing the weight as like the other pill might be at least beneficial, but they use the tagline reduces weight. So many people, I think female, they go for it and they buy it actually. And its name is that, or pill name is available in Australia, is a Yasmin, that pill name. We'll be talking about that one in the gynec. So I just compared this one. So when something has a weight loss property, it can be a branding thing as well. Tagline for marketing as well, right? And DPP4, the drug name is sitagliptin and all this thing. The same one information, stop taking it if you have acute pancreatitis. So you can understand the complicated new drugs we should not use in acute pancreatitis, right? And GIT problem, GIT upset is common in all. You see one thing, GIT upset is almost common in all of them. Okay. Right. So, okay, let's hold here for a second. Okay. So whatever the thing I'm telling, just try to write them. Don't worry. I'll be uploading the slides. So anyway, so no problem. If you give IV fluid insulin to a diabetic ketoacidosis patient, so what's next? Please understand the question. This is our AMC question. You already give IV fluid. This was first line. Insulin, second line. Now what to give next? Is answer is, potassium. Why? When you give insulin, okay, the potassium enters into the cell. So in the extracellular fluid, the potassium suddenly becomes low. So in order to cover that one, we have to give supplement potassium. So supplement potassium we have to give. Okay, so this is the thing we need to understand. So IV fluid first, then insulin comes, and then this one. IV fluid, then insulin. This is so important question, guys. High likely, many of you will get this question. Easy question, maybe that's why people don't upload in the groups, but this is an easy question, often comes in the exam. So giving potassium, here some goals are given, but I'll be uploading the slides, so you will be later writing it for your own interest. They will never ask. They will never ask. Okay, this particular things. I mean, in which case, how much to give, they usually don't ask it actually, rather than what is the immediate management, like diabetic ketoacidosis. Like most popular question from diabetic ketoacidosis, a patient presenting with diabetic ketoacidosis, they don't mention diabetic ketoacidosis, they mention a patient presented with unconsciousness, the patient's age is just 20 years, so likely a complication of diabetes type 1, right? I repeat, diabetes type 1 complication is more common with diabetic ketoacidosis. Okay, because there is no stock for insulin, so suddenly get into total, this problem thing happens. Suddenly sugar level is so high, patient get into diabetic ketoacidosis, right? So you have to remember in that way, and that acid smell, cause small breathing, hypotension, patient is a deteriorating level of consciousness. Okay, body seems dehydrated a little bit. I'm sure you have seen patient in your life. Okay, so just try to imagine how a diabetic with IV fluid. In IV fluid, which one? The normal saline. Because whenever you give normal saline, it will correct the electrolyte. Normal saline we always started with, it collect the electrolytes so quickly. Okay, so potassium is electrolyte, so it will be corrected as well. All right. So hyperosmolar, there's a complication. You can see one thing, the sugar level could be extremely high. Sugar level could be extremely high. All right, please do remember this one. All right, and electrolyte can be vary. You see the potassium and this thing can be affected definitely. Right, so you keep it in mind. This could be an extra sort of note. I would say nice to know, but you never know. It will start asking actually. So very high sugar level, type 2 diabetes mellitus. Okay, so dipstick highly positive for glucose, key line, right? Okay, now it comes in terms of diabetic food. As you can see, diabetic food care, it is so important. Diabetic food care. Before I start, let me check my line. If you have any question regarding this part, you can tell. The line is absolutely clear. I just take the feedback from Mr. Khaled and others. Line is absolutely fine. I'm also checking with another device. No problem. Noted. Okay. Any question, guys? So every time I think monitoring is not good, I think, rather than asking. So any question, guys, you like to ask? I want to answer. Yeah, they also said that company challenges me, like if any problem, we will change our name and this kind of thing. No, I think since yesterday we know, because we changed the line. This is a broadcasting line. It's like dedicated, very separate actually, highly expensive line. So it's not possible, if anyone, no need to, ever answer that, I have problem, because it's not possible to have any problem from now on. As I mentioned, this is a very different line, guys. As I mentioned, this is studio line. Any other question, guys, like regarding this thing? Treatment of HSS. Yeah, this is the like yeah, definitely. You definitely have to treat. Like, see, sugar level so high. This is a very basic thing. Sugar level so high. I think I should give lot of, so if so high, definitely insulin. Definitely insulin. So high, so you can't control it easily, right? So insulin. Good question. Anything else? Nice question. That is a Dr. Satinder asked that one. It's a very nice question. Diabetic food not started. I'm talking about the others, like, so far what we have discussed. Any question regarding that? No, no, food is not started yet. Okay, food we'll be discussing. No. All right. I think Dr. Suraj got his answer, and yeah, from now on everything would be perfect. Yeah, because I just contacted with like, it's okay. Even I have to pay too much, I think, but it's okay. It depends on the line, right? All right. Mode of administration, you check from the books. Okay, these are easy things. About diabetes, ABCD. Can you specify in which case? If you say, see, we all know in diabetic cases, the insulin thing we give the subcutaneous. Okay, just answering that question. Normally, the subcutaneous and all this thing, but diabetic ketoacidosis, immediately we give IM insulin. IM insulin till the blood glucose level down to 10 millimole per liter. We keep giving IM insulin in certain interval till the blood glucose is down. But normally insulin, as a general person, we give subcutaneous. But insulin can be given in drip, insulin can be given in IM, insulin can be given in subcutaneous. All right. So I think that's the answer of your question. But not a very interesting question. You give IM in that case. Not a very intelligent question, Dr. Tasina. Okay. No problem. We can solve these things later. That's why the groups are. All right. No problem. Any more interesting question, guys? Diabetic food we haven't discussed yet. Diabetes food we'll go for discussion. Okay. You check. You Google it. Okay. For which drug to prescribe in liver disease, in diabetes. You check the chart or you check the slide later. Okay. It's already told. Okay, let's focus on this. I'm just looking for intelligent question, not the question which can't be get from the book. Question means what? Question means it should be a very conceptual question that helps you and helps the others at the same time. Okay, but the question uh, that might be, if you open the book and you will get it, that should not be asked actually. Yeah, all right. Has to be intelligent question. Okay, moving forward to diabetic food. Okay, this is a 5-star topic for our AMC. This is a 5-star topic for our AMC. If you see, this is a traffic light, so that means there are some red zone, green, yellow zone, and green zone. So red, yellow, green. There are certain zone. So how this question is presented in AMC exam? They will be giving you a picture of foot and there will be an ulcer, and now they will ask you how to prevent further complication in other food or how to prevent complication. So how, they will be asking question about preventive measurement. Okay, preventive measurement. They'll be asking question about preventive measurement. All right. So about the preventive measurement, if as you can see that glycemic control, diabetic foot care, these two options are usually given as A and option B. So often, people do one thing, they choose the glycemic control thinking this is diabetes, and then diabetic related this complication thing are there. But in diabetic foot cases, this is the only one unique thing where we have to go for foot care. I repeat, diabetic, this foot related stuff, foot care over glycemic control. If you see, foot care over the glycemic control. All right. So foot care over glycemic control. So this is important. As you can see, diabetic foot. Yeah, this is how diabetic foot related ulcer is known as neuropathic ulcer. And it is also tested topic. Neuropathic. They'll give you a picture or they will tell you in the pressure point. Guys, please take note in AMC. They mention pressure point. Pressure point. So pressure point related ulcer is related to diabetes mellitus related ulcer, which is called neuropathic ulcer. All right. So this is the thing you need to remember probably. And yes, this chart is very important for us. This is one of the chart which is so important for us. They'll give you a picture. I repeat, they'll give you a picture. Example, this leg picture. Let me zoom this one. Yeah. So this one, as you can see. So in this one, they will give you, say the left one, and they will ask you the patient who is suffering for diabetes and now he develops ulcer. I repeat the question. A patient who is having diabetes for many years and now develops this kind of ulcer. What type of ulcer is this one? Okay. So you need to understand the areas and the picture. So this is somewhere it is called medial greater area. Please write this line. Medial greater area. Medial greater area. This is somewhere related to venous. All right. So medial greater area is related to venous. Either they will give you picture or either they will mention medial greater area. So if they mentioned about malleolus and things like that, it can be arterial ulcer. Malleolus, if they mention, it can be arterial ulcer as well. Neuropathic ulcer. See guys, this is pressure area. Neuropathic ulcer, pressure area. All right. So this is an important thing to remember. Neuropathic ulcer, pressure area. Now there was a complicated question. Let me talk about a complex question. It was asked in diabetes mellitus, which ulcer, what is the most common site for ulcer? Diabetes mellitus, most common site for ulcer. Options were given, two options. Let me write the two options. One was given between first and second toe. First and second toe. I mean this one, like this one. And another is here, heel. Another was given heel. So first and second toe and the heel. So it was a complex one because we know both are quite common, but then which one to choose? So all were in dilemma, but since we had some discussion, we put ourselves to a decision that, okay, this one should be the answer. So any idea which one it should be? So we decided the one I'm telling you, you can participate of your own. The one we decided, that one is heel actually. So heel is even more common actually. Okay, some Australian article we found, but if you guys found a better article, definitely do let me know in the secret group, or you can call me. Guys, our calling hour is Friday. People, when they remember, they usually try to message. It should not happen. We are very busy people. Definitely, it's better. We always prefer calling things. Definitely, if you have emergency, you can always call me. If there is emergency came up, you are going for travel, this is not my emergency, okay? Just to tell, actually. But emergency includes accidents, serious sickness, hospitalization, this kind of thing. I also have patients, so you can understand I also have to deal sometimes emergencies, actually. So okay, so if you are looking for me, even to Mr. Khalid, to hand over phone, it should not be like, I'm going to miss my class. So this is never an emergency for me. You miss your class, that's your deficiency. You should be very regular. I'm very strict teacher about this kind of thing. Even when I was taking class in overseas, I was very, very strict, but still I ranked number one, because by heart I was very good. But they understand one thing: I'm strict because the student will always be trying to, no matter, you guys are much mature now, but once someone is a student, is always been a student. Okay. I myself is maybe a student. It's like that, actually. Okay, so it's the tendency is always there to, okay, let's just try not to do this thing, and so the strictness is good in that sense. When you will pass, I'll be even more friendly with you, right? So many I have very good, friend like connection now after they pass the AMC. But but till now I have to make in very angry Gabbar Singh image, actually. Okay, so that everyone follow and understand the instructions and all this thing, and attend all classes. I'm telling you, attending all classes will give you highest chance to pass the exam, actually. So it's whose benefit? Definitely your benefit if you pass the exam. Right now, the summary of this one is venous ulcer, arterial ulcer, and the neuropathic. These three types of ulcer will be asked. Second important thing, a complex one, first and second toe, and the heel. Okay, we decided heel, but we don't have so strong evidence. One article we got just, actually, but it was not from book. So you guys' job I'm giving to find out this one, that which one is more common to find in one book. Okay, so this is a important stuff, actually. Okay, so this type of thing is interesting, like searching some books and find it out, so it's nice. Next one we are going, oh right, we have a question waiting, I guess. So what is the diagnosis they're asking? 12-year boy. Now once you see this word 12-year, it should strike your brain. 12-year, previously healthy, hospitalized, polyuria, polydipsia, polyphagia. So diabetes and 12-year, this could be type 1, first of all. So you should keep thinking about diabetic ketoacidosis. Very interesting, right? Because that's a complication. Okay, now I don't know if what is it. Vomiting, abdominal pain, temperature, blood pressure, so hypotension. These are the things. Physical examination shows lethargic boy. Glucose is rocket high, we can see. This is potassium. Potassium is looks a bit up. W is interestingly, so infection. All right, pH is down, decrease the pH, so you can also see. All right, so these are the certain things. So what do you think what it is? Now this is diabetic ketoacidosis, and this diabetic ketoacidosis was precipitated by infection. This diabetic ketoacidosis was precipitated by the infection. Which infection? Yeah, anything it could be, right? So it can be precipitated by infection. So this is the same thing happened here. All right. So diabetic ketoacidosis for AMC, you learn the clinical feature, you learn the investigation, you learn the management as well. Okay, we can do the ketone bodies. Okay, we can do a lot of other stuffs we can do. Okay, so this is important. Now let's get into the recall topic, guys. Okay, as I mentioned, that particular topic will be coming later on. I mean that slides on the topics will be going for overview, but after doing the recall part. So we're getting into diabetes related recalls. So diabetes recall is just starting, guys. Should I give 1 2 minute break? I think 2 minute break. I think 2 minute break for all the good doctors out here. All right. Yeah, sometimes we try to be a little strict, but please don't mind. It's always sometimes for betterment, actually. Right. Actually, there's a good doctor. There's a nice TV series nowadays. If you want, you can watch that one. Okay. A autistic boy who becomes doctor, actually. Very nice. I'm watching it nowadays. Grey's Anatomy, House, The Good Doctors, Chicago Meds. Right. All are nice. So, okay, guys, going for 2 minute break. We'll be coming back after 2 minutes break. Thank you. Okay, dear doctors, we are back after the break. All right. So, are you ready, guys? So, for this recall part, healthy discussion is expected during this part. So, we'll be discussing certain things. Right, great. So, diabetic recalls starting, guys. Now, this question states someone named Melissa, as you can see, someone whose name is Melissa. So now, if you can see diabetes for 5 years, she's on insulin and certain other drugs. She's going to start Ramifil for 10 days. His creatinine is 1.3. So what to do next? So creatinine is 1.3. So what to do next? So this was the question, actually. All right. So what do you think? So in this one, the answer we're going for as, you know, so no use of probably IUD, use of alternative contraceptive, use of alternative contraceptive. This is the answer here. Yes, in this case, it is better we go with another alternative contraceptive. Why? The person is going to start rifampicin. Rifampicin has interaction with oral contraceptive pill. So what is the answer here? Rifam. Okay, let's take the pen. So if you remember rifampicin plus oral contraceptive pill, it will be failure of OCP. It will be a failure of oral contraceptive pill. All right. As I mentioned, no side talking. Dr. Pooja, warning, first warning. Next time it will be blocked immediately. Okay, except for discussion, no such things. The file will be providing. It's too wise, too interested during the class. Okay, focus on the class. Few things need to write. If you want to ask, you message her. That will be okay. It's not a party place, it's a discussion place. Focus what we are teaching. So first warning to Dr. Pooja, strict warning. Next one is just direct block. All right. Okay, let's take a 2-minute break. Okay, guys, so let's come back. There's a thing. The next question, has a little bit problem. As we can see the next one, if you have third nerve palsy, which features indicate that it is not due to diabetic retinopathy? Now, we know one thing, if it is due to diabetic retinopathy, it can be related to third nerve palsy. And one of the third nerve palsy features are eyes should be down and out. Okay, one of the thing is eyes should be down and out. So this question probably has little difficulty, in this case, not due to. So we feel like this question has some problem. We feel this question has itself some problem. We decided though as B. So decided though as B is the answer, but I think this question usually have some problem. All right. All right. So this is the answer is B. Okay, just pick it as B. Some of the cranial nerve palsy which you need to learn. I'll give you guys option to ask question after a certain portion. Okay, I'll give you guys option to ask question after certain portions. So no need to ask any question now. Okay. All right. So just participate now. You write your problem, and when it will be asked, then ask that question. Not immediately after each question. Okay. Only the class will be hampered because of that. Okay. So I'll give you guys option after a while, like about asking question. That's how we can solve the problem. All right. So some of the cranial nerve palsy those are important is 3, 4, 5, 6, 7. 3, 4, 5, 6, 7. So these are the name. Please do note. Okay. What is the choice of treatment in sulfonylurea-induced hypoglycemia? So choice of treatment in sulfonylurea-induced hypoglycemia is octreotide. I repeat, this is a tough question, so hence I'm not asking. The answer is octreotide for this one. Answer is octreotide. So please take note. Sulfonylurea, just take a note. Sulfonylurea-induced hypoglycemia, octreotide. Okay, taken from this index journal. Okay, next one is coming. A 60-year-old Pakistani man is your patient for last 10 years. He has a history of type 2 diabetes. Okay, so 60 years. So diabetes probably developed later. So that is the reason type 2 diabetes. Last 10 years with poor glycemic control and suffers from hypertension, hyperlipidemia. Looks like the person might have also metabolic syndrome. But let us see what is the question is asking. What will you advise him about retinopathy screening? See, they started with one thing, but they asked something different. So this is the one of the important thing. You just read the question first line and just check the last line and just look around the stem. You'll get a full idea in just 5 or 7 seconds. This is another thing I do all the time. I just check the first line, just it's like a quick scanning. Then I check the last line. Oh, it's a question related to retinopathy. So I'm giving my brain a space. Okay, the question is regarding diabetes and the retinopathy, and probably they will ask you about screening of diabetic retinopathy. Okay, so this will give me a very clear view. So annual screening every 2 yearly by ophthalmologist. Every 2 yearly by ophthalmologist. No screening is required. So no screening is required. So any idea? So now it brings us to a point that annual screening by optimist, 2 yearly by ophthalmologist actually. So see, if you go to Australia, or if you are already in Australia, you know the system well, right? Optometrist, in our countries like in Bangladesh, neither in India, neither in Pakistan, they don't have anything special to play. Neither people, they value them, to be honest. But if you go to in Australia, these optometrists, they have lot values. Okay, they do proper courses and they know a lot of things actually. Okay, so this is totally fine. Annual screening by optometrist. Annual screening by optometrist, this is a totally fine answer. Okay, if it is necessary later, optometrist can refer. Remember one thing, optometrist can refer to ophthalmologist too. Okay, so A is a 100% sure answer. Sometimes some answers I'm not sure, so I'll be telling you this one I'm 100% sure about the answer. So this is the optometrist. And if you just walk around, you will see so many optometrist shops. They are doing testing, a lot of other things actually. Okay, so annual screening by optimist. You don't need to bother the ophthalmologist. You don't need to bother the ophthalmologist for simple, screening purpose. Actually, this screening they can do easily. All right. So answer, final answer is annual screening by optometrist. Yes, later, too yearly can be ophthalmologist or the optometrist feels like. All right. Now is a picture given about acanthosis nigricans, which we started with initially. Now things are correlating, right? Next one, okay. A 8-year boy has shrunken eye, thirsty 4 times, history of vomiting. What to do initially? Random blood sugar is 33. That's now very high. Random blood sugar 33. Now that's very, very high. So what do you think? So answer for this one is, since IV fluid not in option, if IV fluid in the option, we choose IV fluid. It is a diabetic ketoacidosis. Answer here is ABG. I repeat, the answer here is ABG, arterial blood gas, because the pH will be down. You remember diabetic acidosis, some of the features, the pH is, one previous question, the pH was less. So the pH you can identify the metabolic acidosis by doing a simple ABG. Okay, so the answer is ABG. Hemoglobin A1C, it's not for acute cases. Hemoglobin A1C is not for acute cases. So B is totally wrong answer here. So A is correct answer here. Okay. So management of diabetic ketoacidosis, arrange urgent hospitalization. This is, mandatory, and commence starting IV fluid. Also, you can go for insulin. So first line is always, IV fluid. Just remember one thing. First line is IV fluid actually. Okay. In the management of diabetic, then comes insulin, then comes potassium supplement. Now, the question some guys are looking for is this one. A 40-year-old diabetes mellitus patient have a wound infection following trauma. After swab and culture, beginning of diabetes, what will be the next step of management? We can see wound infection after trauma. Now, the duration is not mentioned. This is the reason the question is not very complete one. The duration of the trauma or the duration of having the wound infection, it is not mentioned. I repeat, the original question will mention you about the duration here. I repeat, the original question will mention about the duration. So there is a wound infection, she was, having a injury in her leg, say 1 month back. So what to do? So let's just think it's a recent. Let's just think it's a recent. Okay. So if it is recent, so probably we'll do an X-ray. Since we think it's recent, so maybe X-ray. Once diagnosed diabetic ulcer, patient come with ulcer less than 6 weeks. Okay, go for X-ray. Please mark this line. Diabetic non-healing ulcer. Please give a headline. Okay, let me also draw for you guys. Diabetes mellitus non-healing ulcer. I'm also trying to read for you, so you guys also write few things. Diabetes, okay, ulcer, foot ulcer. Okay, headline is non-healing ulcer. So if it is less than 6 weeks, we go for X-ray. More than 6 weeks, MRI. Now, AMC always likes to play. They will give you cutoff value. They'll give you 6 weeks. Now, what to do with 6 weeks? I said, or John Murtak said, more than 6 weeks or less than 6 weeks. What if they give 6 weeks? If it is given 6 weeks, means already the level is raised. If 6 weeks means already level is raised, so you will go for again MRI. Okay, so more than or equal. So just make like this, more than or equal. I'm sure we did it in math, right? More than or equal. So this is MRI. So more than equal, this is MRI. All right. So it's a weak one actually. Okay. So, since nothing mentioned, why I picked up X-ray, because nothing mentioned. So I think it's recently happened, less than 6 weeks. So going for a X-ray. Yeah. But original question will give you exact idea. Okay. Next is diabetic foot ulcer with erythema on the whole foot, asking for most appropriate next step of management. Diabetic foot ulcer on the whole foot, asking for most appropriate next step of management. Actually, this file we are using, it's taken from our AMC bestseller actually. Okay, so it has a standard question banks and things on recalls. So I'll be uploading this part, don't worry. Diabetes, we uploaded all the thing. This whole part is taken from the MC bestseller, and 1-2 more new things are added on that one. Okay, you must be asking, like, doctor, what you're using actually looks a little different. Yeah, it's the book one we are using right now today. All right. So diabetic foot ulcer or erythema on the whole foot, asking for most appropriate next of management. See, diabetes, the organism that's like to taken over are sometimes gram negative. So in order we want to cover the gram negative, so IV tigersilin, this one, IV tigersilin. All right, IV tigersilin. So A, correct answer, no doubt on this type of question. Okay, there is no doubt. So you go for the treatment to prevent the anaerobic organism. I repeat, we give this treatment. Why? To prevent anaerobic organism. Now there's a next question coming up. A picture of large ulcer on the medial side of the leg. I repeat, large ulcer on the medial side of the leg. Now, anything you were guessing why that slide was important? Looks like, okay, venous. I think it's a Ricoleur's version. They will never tell you. History of non-healing for 12 months. What is the management? Oh, so this is an interesting one. So medial side, there is a non-healing ulcer. So medial greater area. I repeat, this ulcer is related to medial greater area. So this is a venous ulcer. Now, I didn't tell you one thing. What is the treatment of that venous ulcer? Now you guys tell me. What is the treatment of this venous ulcer? According to John Murtagh, you have to tell. What is the treatment of the venous ulcer? If you have inquiries, guys, while reading this one, please write it to your notebook or in a separate page. When I will give you option to ask, feel free to ask that time. So in this one, no, like, I think it's a misleading, guys. So in this one, if you see, answer is leg elevation and rest for 2 weeks. This is taken from John Murtagh. This line exactly taken from John Murtagh. If you see the venous ulcer, it's given in John Murtagh. It's a venous ulcer, guys. It's not the typical arterial ulcer. This is venous ulcer, guys. So the treatment for venous ulcer is leg elevation and rest for 2 weeks. So A is correct here. We know we have to follow John Murtagh. Yeah, your lot of practical knowledges are coming. I can understand, like typical diabetic ulcer, we do debridement with washing with normal saline and lot of other things. That thing is coming, but this is, they're talking about the venous ulcer, guys. So leg elevation, venous. Just remember this word. Okay, I'm just writing so that you remember. So venous ulcer, then if you just draw the leg, malleolus, this part involved, say medial greater area, this indicates venous ulcer. So management for this venous ulcer is, what is it? Leg elevation and rest. So I just write for you so that you write also. All right. Next question, I think it's also kind of similar. So just telling you the answer here. Diabetic 65-year woman, an ulcer on the foot for 7 days, came for hospitalization. Surgical debridement is done, an ulcer 1 centimeter and oozing clear fluid. Okay. So an ulcer on her foot. All right. So what to do? So this is a question where we think already there is ulcer on the foot for 7 days. Ulcer on the foot for 7 days and debridement is done. I still answer 1 centimeter and oozing, what's best? So we know the non-healing, those ulcer is there, okay, in the foot. Probably it's arterial. Probably it's arterial. We don't have the picture. So in that case, the best idea, I think this is the practical question one, the one you are looking for, the practical, what you guys do. So dressing and checking the wound every day. Dressing and checking the wound every day. This is the thing we all do, I think, in day-to-day life. Okay. So this is the typical one. If it is not mentioned, remember one thing. Remember one thing. If it is not mentioned what type of ulcer, uh, you better start thinking as that arterial type of ulcer or that common type of ulcer. In that case, you do the typical dressing, okay, or it can be the neuropathic ulcer one as well. It can be neuropathic ulcer one since the person is having diabetes. So the best idea is dressing and checking the wound every day. Okay, nice one, Dr. Zafar. Nice one, yes. So it's not healed, yeah, because there's some signs are there. No past mentioned, right? No such past mentioned. Okay, similar question, skipping. I just put one line, diabetic ulcer heals quickly with regular and proper sterile dressing. When it is asked, best or most appropriate. Okay, diabetic ulcer heals quickly with regular and proper sterile dressing. Right. Now, diabetic patient controlled by metformin, patient on multiple drugs. Which drug you need to stop prior 1 week of elective surgery? This is a tricky question that often comes. Drug which needed to be stopped, a week prior. As I mentioned, please write down your question things. When you will be asked later, you ask that time. Okay. So these are tested topic. No need to we can do the inquiry later. All right. The diabetic patient controlled by metformin, patient on multiple drugs, which drug need to stop 1 week prior an elective surgery? Answer is an NSAID. So here is the few information, extra informations are given here. So it is recommended to stop all NSAIDs 1 week before the surgery, taken from a book. So answer is B, indomethacin. Next question. I think easy one. 67-year-old type 2 and has ulcer on the medial malleolus. It started 2 months ago after a scratch at the same site. What is the diagnosis? Ulcer on the medial malleolus. So the diagnosis is clear. So this is venous ulcer. Ulcer on the medial malleolus, that particular area, greater area. So it's probably venous ulcer. Okay, some doctor, I think in the last one, they have a little doubt. On the metformin. Metformin, we don't stop 1 week prior. Metformin, we stop just before actually and switch to insulin. Okay, not 1 week. All right. It is asked 1 week. If 1 week asks, it is NSAID. Okay. No problem. Okay. There's a handbook reference, guys. We have one diabetes handbook reference, page 391. Page 391. One extra handbook reference. Please take note. Right. Now, another learning type thing, the options were not available. So, 67-year type 2 diabetes, painless ulcer over the plantar surface of the head of the third metatarsal, plantar surface of the head of the third metatarsal. So it's below, I think, in this foot area, pressure point area. So I think it's a neuropathic ulcer, planar surface or plantar surface of the head of the third metatarsal. So it's a in between, in the bottom of the foot. So it's a neuropathic ulcer. So you see one thing with the ulcer, they would be asking a certain type of question. So ulcer, this is a certain type of question they're asking. Okay, next one, as you can see, in diabetic patient, what will you check 2 yearly? Very interesting question. Again, doctors, one very interesting question comes in diabetic patient, what will you check 2 yearly? Think about this one. So BP, foot care, eye examination. The question is what you will check 2 yearly. So answer for this one is C. Even though the best, I think, optometrist by yearly, that's the best answer. Previously we learned, basically even checked by, optometrist by yearly, that's best answer. But since that's not in the available option, 2 yearly, I think you can be checked by an ophthalmologist. 2 yearly, you can be checked by an ophthalmologist. Yearly by an optometrist. Okay, so we would go for the eye examination here. Foot care, unless you don't have any issues with foot, separately, it's nothing to check. So I think this is the better. So this kind of weird question will be there. So you have to be careful. Now, next one, a scenario of patient under medication with gynecomastia. He has hypertension, he has diabetes, okay, and on several medication. What is the following cause? You have ABCD, 4 options. What do you think? So in this one, so this is a question, drug related gynecomastia. I repeat, this question related to drug induced gynecomastia. Which drug is very potent causing gynecomastia? So answer for this one is C. Like, so potent drug that is causing gynecomastia is spironolactone. Potent drug causing gynecomastia, it is spironolactone. Okay, just remember this one well. Potent drug causing gynecomastia. So with the gynecomastia, this chart will help you guys a lot. Guys, this chart will help you guys a lot. Please take note from this chart, or someone take a picture and please post in our secret group. So this question can be tested in various ways. So 15 years, I can't show you the gynecomastia picture because Facebook has a lot of restrictions. Not only Facebook, any video with, breast picture, we can't show actually. So 15 years can be given. Okay, I repeat. Okay, let me draw this part for you. Okay, and let me draw this part for you. So gynecomastia related few things often comes in AMC. So gynecomastia. So one, it is given 15 years, a boy is having gynecomastia, what it could be. So often options are idiopathic, like no cause found, pubertal, then steroid or drug, All right. So it can be among the lot of options you have to choose. So with 15-year, the answer is pubertal, because there is a topic in John Murtagh. In 15 years, there is a topic in John Murtagh. Okay. It is called pubertal gynecomastia. Don't worry, thing will be fine. Pubertal gynecomastia. So this is a separate topic. What happens here? Like, see, during puberty, the male breast also a little bit enlarges. Okay, so it is common in a boy of 12 to say up to 15 years. So 12 to 15, the boys also look quite weird that time, right? So 12 to 15, like it is said, after puberty for 2 to 3 years there could be pubertal gynecomastia. So it also includes the 15 years. So why 15 year I wrote here? Because there was a AMC question was tested. AMC question was tested. So 15-year one, among these options, we will choose pubertal gynecomastia. Now, the second one, it was tested 17 years. Now, the next question is coming with 17 years. Can it be pubertal? Answer is no, it can't be pubertal. Pubertal is 2 to 3 years after the puberty, which is like 11 or 12, the puberty started in boys. So it can be maximum up to 15 years actually. So 17 years, nowhere it can be pubertal. So again, if I give you options like idiopathic, then pubertal, or if I say drugs or steroid, whatever I say, in this one your answer would be idiopathic gynecomastia, because no such cause found. So this is idiopathic. Now next one is coming. They often put 19 years. All these are tested in exam, guys. That's why I'm telling the ages in that way. I do research with all of them. So one came with 19 years, one came with 21 years, both were same. One special thing was mentioned. There was a sports person, like a football player, professional football player, then a basketball player. So some were like this, and now they're having gynecomastia. So if I just put all the options now, idiopathic, then pubertal, and the option, drugs, which one do you think is the best option here? So in this case, we think, because since the person is a sports person, so increase the performance, they can use anabolic steroid. I repeat, to increase the performance, they can use the anabolic steroid. So here, the drug is the main thing. So everyone understood this one? So guys, please take a picture of this one and please post it in our secret group later. All right. So I hope so it was not a tough. If you see all this research, so 15 years pubertal, 17 years idiopathic, 19 years drug induced. Clear, guys? All right. Hope so it's clear. All right. And here is the John Murtagh little line. Pubertal gynecomastia subsiding in 2 to 3 years after the puberty. That means it also remains. This is the evidence of pubertal gynecomastia up to 15 years. This is the evidence from John Murtagh. If 18 given, doctor, you can also take the, idiopathic, unless drugs are mentioned. Unless until drug mentioned, you go for drug. Otherwise, you choose the idiopathic. But before that, 15 year, 14 year, you think about the pubertal gynecomastia, right? Doesn't matter with 18 years, okay? No problem. You can choose the idiopathic. But depends, if a sports person mentioned, then you can go for the drug one. See, even 19 year and no drug mentioned, Okay, now this can be interesting question, okay, for some people. If also mentioned, like as I mentioned, someone said 18 year, or even let's say 19 year. If it is mentioned like 19 years, not a sports person, then what would be your answer? Idiopathic, pubertal, or drugs? Now this will clear the conception, guys. 19 years, not a sports person mentioned. 19 years, not a sports person mentioned. We'll still go for the idiopathic one, guys. We'll go for yes. All clear, right? Clinic, all clear. Everything will be clear from the scalp and head and shoulder, from head to shoulder. All right. So, take care of your hair. So this is very, very important, guys. How many of you have hair problem, guys? Male, female, hair fall? Someday I think I should tell something about the hair thing. I think it's a, nation's problem. All right. Yes, let's just change the topic a little bit. How many of you think you have hair fall problem? Doesn't mean bald, that's a different thing. But how many of you think when you were as like 15 or 16 year and now maybe 25 or 30 year? So, all right. Let's see about hair. First thing, it's actually genetic. Is always remember one thing, it is genetic, most cases. Okay, the next all the things comes environmental and how you take care of your hairs. So too many chemicals, color, all right, weather, all this thing makes hair to fall. Also shampoo, not using good oil these days. Nowadays everything is some admixture, impurities are there, so tough to get the solid oil, those our grandmother they used to use actually. So it's not there nowadays actually. The commercial thing is a problem. The hair, maybe the the parachute or any other thing you are buying, the oil, maybe not the good oil. This is a commercial product actually, not a handmade product and all other things actually. So those things, you just be careful actually about using the what is the oil you are using. I think since 90% is female here and they are using some oil or something in their hair products. Definitely coloring hair will definitely make hair to fall. This is one of the thing. If your father and mother's hairline is not good, probably you might have hair fall problem. Also dandruff is another problem, so try to correct the dandruff. Okay, if you have dandruff problem, definitely try to correct that one immediately. This is so important. And stress, we all doctors are in lot of stress. Before MC exam you will see too much hair fall. Okay, nothing to do. So unless you just make sure the you finish the exam first, there's no other way to control those things, stress. So rather than you just finish the exam quickly is one of the thing. Okay. Okay, I think many has actually less extent or more extent. All of them have. Okay, so I also saw my wife taking care of hair. Her hair is very long actually normally, but when she's careful, I mean for 1-2 weeks, then there is everything is good for a month. But when too much workload and not taking caring of hair, like this thing happens so often. And coloring thing, definitely when she did hair color it also, so I also did research on her as well. And also see patients are there definitely, but these are some of the very common thing. You can also use e-cap. Okay, doctors, one thing you can use sometimes e-cap, it works well. This green color capsule, when next time you do something, you can just break that one and you put in your hair, and just keep it for a while. So that's also works really well for the scalp. All right. Okay, one doctor. Same applies to idiopathic for 21 years. If not a sports person, yes, same thing. If not mentioned about the sports person, definitely you go for the idiopathic then. All right, guys, going for the next one. All right. So in diabetes patient, what should be done 2 yearly? See, again, this type of question is coming. In a diabetic patient, what should be done 2 yearly? And I think some questions are started to repeat. So in this one, the answer is diabetic retinopathy, checked by an ophthalmologist. I repeat, checked by an ophthalmologist. Right. No, inshallah, I'm planning to make, every year, you guys should take a new year resolution, what you should do. Some of your plan should be, okay, finishing MC, being Australian doctor, everyone has their own revolution in 2020. So, things should be like that. I made few things like, okay, I'll make a lot of YouTube videos in might be I'm getting bored with AMC things actually, so might be making some interesting YouTube videos on, like, say, hair fall and this kind of thing. I know a lot of things, so I think it's better few things I make for publics as well actually. Let's say just an experiment. Okay, so in diabetes patient, it should be done 2 yearly. Again, same thing, diabetic retinopathy, 1 yearly by optometrist, 2 yearly by ophthalmologist. So we'll pick up the 2 yearly one. Okay, so this is B as a correct answer. Now, interesting one. Gestational diabetes screening in a female with family history of diabetes. Choose the best answer for this patient. Now, this is a very interesting one. This one we also teach in obstetrics actually. This is a basically obstetric question. OGTT 26 weeks, OGTT 26, glucose challenge test 26 weeks, glucose challenge test 26 weeks. Choose the best answer for this patient. Best. So the gestational diabetes, the next one. I'll show you a line, guys. It is taken from John Murtagh, actually. As I mentioned, I'll be uploading this whole file, so don't worry at all, okay? The OGTT should be reserved for true borderline cases. I repeat, OGTT should be, it's also good. A screening oral glucose challenge, 20 to 30 weeks gestation is recommended during the pregnancy. Now, the confusion comes in between OGTT and glucose challenge test. OGTT and glucose challenge. See, OGTT we usually do, no doubt. OGTT thing usually we do, that's so obvious and so common. Actually, in between fasting and OGTT, I repeat, if this question is asked in that way, in between fasting and OGTT, OGTT is a better one. Now, this question comes OGTT versus glucose challenge test. Now, this one, I'm not 100% sure about the answer. It's always been a little doubtful. One thing we are sure this is 75 gram. 50 is not an option. This is not out. So A and C is out. Our doubts are in between B and the D. Now, if you see this line, which is taken from John Murtagh, OG should be reserved for true borderline, like when we are really confused. So in this case, if it's a gestational diabetes screening for a woman with family history of diabetes, she is a risk factor and best answer for this patient. So should you go for OGTT or glucose challenge test? So screening oral glucose at 40 weeks, usually 28 weeks of gestation, or even 26 is fine, is recommended during the pregnancy. You see that this line, oral glucose challenge test. Okay, it's about the answers which want to pick up from John Murtagh, and as I mentioned, in between fasting and OGTT, we pick up the OGTT, right? Yeah, as I mentioned, I'm not 100% sure about this one. I need to double check, I guess, this one. So guys, this question maybe someone can put, and let's we give a checklist. I'm not very convinced, maybe I also need to check this one, guys. All right, as I mentioned, like there are some update things are going on OGTT. So this one we used to answer as oral glucose challenge test. Lately, OGTT has some updates in between fasting and OGTT. That update we did in OBS, but this OGTT versus glucose challenge, maybe we can double check. All right. No worries. Like move on. I have to also leave for the wedding. You can understand. They are waiting for me with the car actually. All right. So Irish background, first trimester. So she is pregnant and diabetic. So how will you screen the gestational diabetes mellitus? How will you screen the gestational diabetes mellitus? So in this one, as you can see, again I picked up this one, but as I mentioned, same type of question. Glucose challenge test 75 as this week. But as I mentioned, I need to double check this one. Right. A patient with type 2 diabetes, metformin this, hemoglobin A1C is little high, blood pressure is this. What will you do next? So diabetes, taking metformin, and BP is this. So which one do you think is more important? Controlling glucose, controlling blood pressure, or all these things? So his blood pressure looks okay to me. So comments antihypertensive. Is this a blood pressure to start antihypertensive? Answer is no. So it is better, you know, we continue the same and ask the patient to maybe just walk and do a little bit thing. So because the patient is already on metformin, so answer is probably no, not really. Like we don't increase suddenly. We know hemoglobin C is high doesn't mean no other symptom. You see this thing, no other symptom. Okay, I mean the complication. Is a one option missing here, guys. One option missing here. Start insulin. Start insulin is an option when complication developed in type 2 diabetes or fail to control everything. So this is not a reason like 6.9. I think many has 6.9. So do we give them drug or do we ask them to increase the dose? Not always. We ask them, you walk and then follow us. So continue the same treatment. Okay. So A, just follow up in this case. Answer is maybe follow up. All right. So here's a goal of management. If you have the John Murtagh book, you will find this chart. Goal of management things are given. You just check these ranges one time. Sometime a question can be made, which one of the following is a correct statement? So this is a memorizing thing, guys. Now this one, I think is not a very tough question, but it is definitely so important question. 55-year-old lady, this is even a 2019 question, very recent as well. We have seen in past, we have seen, or recently we also saw. So 50 years with insulin dependent diabetes mellitus had right leg amputation 5 years previously. Now blood pressure is this. So his blood pressure is also high. BMI is this, triglyceride high, hemoglobin A1C 8.5. No, now it's very high. Fasting is 9.5. Which of the following is the most important to keep her left leg from amputation? One leg amputation done because of a maybe diabetic complication. How to prevent the further other leg to be get amputated? Now you have meticulous foot care, blood pressure control now, so which one do you think? There's a two doubt, guys. It will come. One, controlling blood pressure. Second, meticulous foot care. But you need to pick up what they're asking. Which of the following important to keep her left leg from amputation? If they would have asked you, what is the immediate next step of management? What to do next? I would have answered, control her blood pressure. I would have answered control her blood pressure in that case. But they asked which of the following is important to keep her left leg from amputation. For that one, meticulous foot care, like wearing proper shoes, try not to get hurt. Even there is little ulcer, take care of it. Okay, so this one is important, meticulous foot care. Meticulous foot care. So always check the last line, what they're looking for. Very tricky one, guys. Now, this is the wrong answer. For diabetic foot, tight glycemic. Now, one question is coming. Tight glycemic control is the answer for which one? Tight glycemic control is the answer for diabetic retinopathy, diabetic nephropathy, diabetic neuropathy. I repeat, tight glycemic control is the answer for complication for type 2 diabetes mellitus. If diabetic retinopathy develop or chances to develop, your first line of management is strict diabetic control. Now clear? I hope so. It's a very fantastic question. If I would have been examiner, I would have put this question, definitely. Okay, a pregnant lady with a history of diabetes at 10 weeks, what you will do? Now, this is another interesting question. OGTT versus this one has some updates actually. So we need to change the answer. Previously, we were thinking of fasting blood sugar, but now RSCGP has changed some guideline. They also said OGTT is best, and this stuff thing came, in the ops section. I'll give you the updates actually. In the ops section, I'll give you the updates. So the answer is now changed to the OGTT. Okay, nowadays the answer people are choosing is OGTT. For pregnant women, the best is OGTT. All right. Pregnant women, OGTT. Previously, we used to think fasting blood sugar, but we found references from RSCGP, they are preferring OGTT now in any way. Okay, so you see this question, one question came OGTT versus fasting, and one question came OGTT versus glucose challenge test actually. So I picked up that one glucose challenge test over the OGTT, but I left it to you guys as well. Like you guys try to find out few more things about glucose challenge as well. All right. Now this is a silly question. You can practice of yourself. This is so easy. So they will give you which of the following is incorrect target to achieve. Okay. So you just see this one and you will understand. This is just a practice type question. Simple practice type question. Okay. Answer is given here. I'll upload this one. Don't worry. Diabetic control annual review. These are the thing you can go for annual review, including the eye. I remember one thing. You can go for annual review with optometrist, 2 yearly with ophthalmologist. So these all are the thing you can go for annual review in diabetes. Very, very nice box taken from John Murtag. 45-year with type 1 diabetes annual checkup, ophthalmologist and dot and blot hemorrhage and hard exudate and multiple cotton spot. What is the next step of management? Right. So in this one, the key answer is, this is a tricky one, guys. Dot and blot hemorrhage. This is related to, the answer is D. Non-urgent referral to ophthalmologist. This is taken from Davidson's medicine. Davidson also has a diabetes section and it is much details written actually. It is not recommended. It will be too much for you guys. But this one question, we got the answer in the Davidson's medicine. There's some stages are given. So this one of the stages is non-urgent referral to ophthalmologist. Why? Because of the stage pre-proliferative retinopathy. I repeat, pre-proliferative retinopathy. Okay, pre-proliferative retinopathy. Now this is not a foot related problem. This is ophthalmology, dot and blot shape hemorrhage, hard exudate. So what is the thing? So non-urgent referral to ophthalmologist. Now you must be thinking, when the answer is like urgent referral, Urgent referral, it is required when there is proliferative retinopathy. How do you understand proliferative retinopathy? When there will be new vessel formation, which is called neovascularization. Neovascularization. Okay, then we can call it probably proliferative retinopathy, and that required urgent referral. And this one is non-urgent referral. Non-urgent referral. This was our answer. So our answer was D, and that's correct. So D, correct. Got it? Tricky one, guys. This is a tough one. Don't feel bad if you don't correct it. When I saw myself first time, I also make it incorrect actually. Then I always double check my things. Okay. It means like whatever things I am telling doesn't mean always have to believe me in that way. You can always double check things actually. All right. Now, I think a similar type question is coming. Elderly patient who is known to have diabetes presents to the hospital drowsiness, tremor, confusion. What investigation should be done to help further management? What investigation to help for further management? Patient is drowsy. This is the one information. Patient is drowsy and confused and previously presented with diabetes. I think it's not a very tough question. Its answer is random blood sugar. Whenever a patient who is coming to our ER or emergency department and we know that patient is having diabetes, what we do? Random blood sugar. Very simple. This is a practical question. Often they got hypoglycemic. So it's an easy one. But some of you might think too much and might make it complicated. This is a very easy answer. Which of the following drugs should be stopped 1 week before surgery? I think question started to repeat. It should be, NSAID. Now this is one nice chart which will help you guys. Reading, drug name. So let's say sulfonylurea, then mechanism of action, clinical use, and toxicity. For you, this clinical use is more important. Also, toxicity is more important. Okay. From mechanism of action, one question I told previously it was important, which you need to learn. So this chart is very nice. I'll be uploading this file. Don't worry. This is one part of that AMC bestseller, our that book. All right. Okay. So this was the question, guys. A 62-year renewed in diabetic and poor glycemic control, adherence to diet and current medication, has no other past medical history. Which of the following medication will increase insulin sensitivity? There is a question directly asked, which one of the following medication will increase insulin sensitivity? Now this is a AMC question. Drug mechanism we don't expect to come, but this is somehow tested. All right. So you need to know now, which one is increasing insulin sensitivity. It is not given in John Murtagh, guys, first of all. So it's given in Davidson's medicine. So I found that answer in Davidson because I did my FCPS. So, I had the grip on Davidson. So I knew the answer. Oh, that's the thing that gives from Davidson. But thing is, guys, Davidson reference, they also give you an AMC website actually. So it's not really a book you can ignore actually totally. So they have the authority to make question from Davidson's medicine as well. Now, if you see, this one's correct answer is pioglitazone. And why I'm telling you now. Now, which drugs helps in insulin secretion? Now, please don't get confused. Secretion and increase insulin sensitivity. So, secretion related working done by sulfonylurea, meglitine, and glitazones actually. Okay, so all of them helps in insulin secretion. Now let's come little down. This is a Davidson chart. So some decreased glucose output, some increased insulin secretion, sulfonylurea, meglitine, incretin-based therapy. There is a one which increase insulin sensitivity, and that is thiazolidinedione. This is thiazolidinedione. This is a tough question, guys. If you miss it, don't worry. Now you know. Okay, this is a very tough question actually. Unless someone did MRCP or FCPS, they might know the answer only. Otherwise, it's not possible to know this answer. All right. So increase insulin sensitivity. So thiazolidinedione. So if we come to our question, which of the following medication will increase insulin sensitivity? Answer should be this one. Pioglitazone is a thiazolidinedione. Pioglitazone is a thiazolidinedione. So C is my answer. C is my answer in this case. Happy with the answer? And these charts are taken from Davidson's medicine. Maybe you can check some of the charts, the boxes. As I mentioned, I will give you guys a Davidson box. I have a note we prepared Davidson boxes only. So that can be useful for many of you. All right. This is a weird question. Diabetic and all this thing, metabolic syndrome, wasting of his leg, and which is painful. All right. Pain is also not increased in few distant picture. What is the possible diagnosis? Okay. So in this one, some wasting of the leg and all these things. So this is nothing but a complication of diabetes. Sometimes weird question do come in MC. So this is a complication of diabetes, nothing else. This is a complication of diabetes. All right. And little bit you can see when I upload this file, diabetes and driving, you can just read one time. So driving related one file we will be uploading later when the course will be done. So diabetes related, driving related one file will be uploading. That will help you guys as well. All right. So that's not a problem. Okay, so I think this is the last question. I think one new one. Which one is most common cause of diabetic ketoacidosis? This is a new question, guys. Which one is most common cause of diabetic ketoacidosis? This is a new question of 2019. So, and new means also confusion arises, underdiagnosed, undiagnosed. So insulin dependent, non-insulin dependent, missed dose of insulin, okay, infection. So which one? All right. So I picked the answer D here. I picked the answer D here. Most common scenario of diabetic ketoacidosis are underlying or concomitant infection, that is 40%. I took it from a book. Actually. So 40%, that's indicating infection. So infection is the correct answer. This is the new question we found actually recently. Okay, I'll also look forward if there's more new thing came up. I'll be definitely updating you. But this one's answer is D is the correct answer. So D is correct for this one. Now, not undiagnosed. Any kind of infection. Any kind of infection. All right. So guys, if you have any question, you can ask me now. I'll be trying to give in 5-7 minutes more for that one. If you have any question, you can ask me now. I have to go to I even didn't get ready. I have just 15 minutes, I guess, to get ready actually. Yeah, I have to go to home first, then get ready, then So all the things I have to do in 15-30 minutes. All right. No worries. Okay. By the way, guys, important thing. By the way, so this chart, I was trying to give the outline. If you have any question, you can also leave it here. Now, if you see this one now, guys, now it will look easy to you. Whatever the topic we have just covered, like diabetes, AC inhibitor, OCP, going to steroid reform patient, what will happen? The OCP will fail. Elderly, painful knee wasting, it's a complication of type 2 diabetic amyotrophy. And we also suggested if you can little bit read neuropathy and cranial nerve related problem. Cranial nerve related problem, the eyes will be down and out. cranial nerve related problem, eyes will be down and out. Next, oral hypoglycemic agent. Okay, we learned in details. Sulfonyleo induced hypoglycemia. Answer is octreotide. Sulfonyleo induced hypoglycemia, one word, octreotide. Diabetic retinopathy screening. Annual screening by optimist. Is too early by ophthalmologist. Okay. Black pigmentation in the shoulder, acanthosis nigricans. A child become unconscious for the first time. What to do next? Serum sodium. A child become unconscious second time. Random blood sugar first. Management of diabetic ketoacidosis, IV fluid first. Learn the management of DKA after initial resuscitation, IM insulin, till the blood sugar level down to 10 millimole per liter. Okay, diabetic ulcer, it depends according to the site of, like diabetic ulcer, you remember the site. And also diabetic ulcer, you know the time management, less than 6 weeks, more than 6 weeks, you need to remember. Diabetic foot ulcer treatment, I think we just discussed diabetic foot ulcer treatment. Some cases, I think most cases we need to do the debridement and proper dressing. That's most important. All right. Okay, diabetic foot ulcer, the non-healing. Yeah. So these are the few things. Yeah. So all the recall line I just put here. Dressing, checking every day, most effective. Drug to stop 1 week before the surgery. That's NSAIDs. Ulcer site. For diabetes is pressure point. For venous ulcer, that's medial greater area. Multiple drug, diabetes, hypertension, many questions will be asked, especially what is the choice of antihypertensive in diabetes. You will be giving AC inhibitor. Why? To prevent proteinuria. You will be given AC inhibitor to prevent proteinuria. Drugs causing gynecomastia, spironolactone. Just remember the name, spironolactone. Also, anabolic steroid can do it. Anabolic steroid can do it. But which one is more potent? Spironolactone, more potent. Diabetes type 2, check too early. I by doctor too early. Ophthalmologist 1 yearly. Okay. Gestational we just discussed, but gestational there is always update comes. I repeat, gestational diabetes screening always update comes. Every year this update comes. So whatever I will tell now, after 3 months, if you're reading, your guideline might be changed. Yeah. So normal level, target level, you need to learn. Diabetes mellitus with hypertension, choice of antihypertensive. We already told AC inhibitor is the choice. Oral hypoglycemic mechanism, especially insulin sensitivity. Now you remember the insulin sensitivity is by thiazolidinedione. Thiazolidinedione, that's the most important thing. Okay, diabetic retinopathy and that one, hypertensive retinopathy, we'll be teaching in the ophthalmologic section. Which stage of diabetic retinopathy is an emergency? Okay, it's proliferative one. Leading cause of blindness in Australia, that's trachoma. Sometimes, you will be confused and, trying to answer diabetic retinopathy, but it's not. Leading cause of death is trachoma. Side effect of oral hypoglycemic agents, we just give you the chart. You'll find it. Oral agent, insulin sensitivity is just mentioned here, actually, nothing else. So sensitivity and secretion are different. I repeat, sensitivity and secretion are different, which we talked in the slide. So thank you so much. This is Dr. Sherrier. If there is any question, you can, I'm just putting a inquiry box. You can ask that one, no problem at all. So this file will be uploading, no worries. After some time, give me some, I have to go to a program. You can understand, I could have canceled the class. And about the endocrine, the theory, I'm just uploading a video. You just go and see that video now, okay? For endocrine, that will be available for next 48 hours. Not today's video will be available. Endocrine theory video I'm uploading now. That will be available for, next 24 hours. So thank you so much, guys. Have a great day. Yeah, I could, as I mentioned, I could have missed the class, but I never try missing any classes, actually. So, you should try to work hard, same as me, or even double. All right, guys.